Ladies and gentlemen, welcome to the Knowledge Exchange podcast. I'm your host, Daniel, the lead mentor at the Knowledge Exchange, where we run online courses and online mentorship. We have a 10-minute complimentary consultation for mentoring only this week. So considering all the changes that we are experiencing with telehealth, reach out if you would like any further help and guidance as we make the transition during this crazy period. So back once again with psychologist Anthony Berrick. We had a really productive and eye-opening chat in part one, where we talked about the ACT concepts, principles versus CBT principles, and we were diving into the psychologist's approach to pain and dealing with people who are experiencing pain. So some really juicy topics in part one and some juicier topics in part two. I'm really excited to dive into it today, once again with Anthony and his pet snake in the background. So thank you.
Cool.
Thank you, Anthony, for making
Thanks
the
for
time.
having me, Dan. Cool.
Awesome, mate. So we were chatting earlier about some of the similarities that we can pick between a person experiencing chronic pain and someone with a panic disorder. So we're not saying that they are the exact same conditions, though there are some similarities that might be useful to dive into. So if you could start us off, Anthony, with perhaps what is panic disorder, if we have a definition, and then going from there to what are the similarities?
Yeah, sure. So the reason that I made that comparison is that both these conditions are kind of problems that someone might have with a system that is actually supposed to be protective. So in the case of panic disorder, the person has become kind of stuck and entangled in a sort of a vicious cycle with feelings of fear, where fear is supposed to function as a protective emotion. But in the case of panic disorder, it ends up causing the individual problems where they basically end up becoming almost like phobic of feelings of panic. And as a result, get stuck in this cycle of avoidance and escape, and trying to mount this agenda of control where they want to get rid of these feelings of panic. So just kind of quickly talking about what panic disorder is. So it's defined as where someone has repeated panic attacks. And even the definition of a panic attack is quite difficult to nail down, because everyone's sort of individual experience can be very different. But officially, we have 10 experiences that are identified as sort of common experiences in a panic attack. And if you have 4 or more of those occurring, it counts as a panic attack. But if 4 out of 10 means that actually you could get 100 people and they all have a slightly different experience of a panic attack. So there is no sort of one thing that is a panic attack. It varies a lot from person to person. But I think most people who have had panic attacks would tell you it's a pretty horrendous experience. People can feel like they're losing their mind, they're going crazy, they're about to die, they might have an out-of-body experience. It can also be very embarrassing if it happens like in front of other people. And a lot of people who have a panic attack, they end up in emergency, presenting with chest pain or like, they've called an ambulance because they feel like they're about to die. So it's pretty full on, and you can imagine that having an experience like that, you would want to never have that happen again. And this is where then problems can arise, because people can then end up going down this path of sort of doing everything they possibly can to avoid having another panic attack. And so that might mean avoiding going to certain places, avoiding certain activities, avoiding certain sensations in their body, like their heart rate getting too fast, or, feeling dizzy or out of breath, because that might have been something that was an antecedent to the panic attack that they had. So repeated panic attacks, or ongoing concern about having panic attacks, combined with some kind of functional impairment, is the definition of panic disorder. So if you have lots of panic attacks, but it doesn't really get in the way of you living your life and doing things that matter and having good relationships and holding down a job, and then and those experiences are not causing you a huge amount of distress, then you don't have panic disorder. So it's not the panic attack that makes the panic disorder. It's the impact of the panic attack on that person's ability to live their life. But here's the interesting thing. Panic attacks are completely harmless. So this is kind of like the crucial piece of information that someone suffering from panic disorder needs to begin the journey to recovery, in the same way that someone with a chronic pain condition needs this piece of information that they are safe to move in certain ways, even though there is pain when they do so. Because without that information, you don't have a starting point, really. If in normal circumstances, fear is a very good indicator of danger, in the same way that pain is usually a very good indicator of potential damage to the body. But in panic disorder, fear, as it relates to panic, is not providing useful information. Just like in a chronic pain condition, pain is no longer providing useful information to that person. And so the way we treat panic disorder is through a process of exposure-based therapy, where we invite the individual to confront these feelings of panic and anxiety in a way that they feel willing to do, and continue to engage in meaningful, life-enhancing activities without getting kind of drawn back into this battle with those feelings of panic that they have been engaged in previously. And over time, what happens is, so I was saying to you earlier, like the fear system that we have in our brain, the pain system that we have, we know they're very complex systems. They're also incredibly sophisticated. They're not dumb systems that, like, once you learn to be afraid of something, you're stuck with that forever. Or once your brain learns pain, you're stuck with that forever. These systems are flexible and they respond to feedback, but they need feedback in order to be recalibrated. So if your brain is sending like crazy fear signals, in the case of like panic disorder, that don't match up with the actual danger that you're facing, then through your behavior of continuing to live your life and not treat those experiences as if they are harmful, that gives the brain feedback that you're safe. And so the brain takes that information on board and it uses that information the next time around when it's calculating whether or not to activate that fear alarm. Does that make sense?
Yeah. So what I'm taking as well is that there's the fear of fear. And in the same way, we can have patients, clients that experience fear of a flare-up or fear of doing damage and fear of pain, even if they're currently in this present moment not experiencing any pain. So they're already anticipating the consequences, and their systems have been wired to be extra sensitive to those scenarios. So it's protective for them. And
yeah,
as we mentioned with the inhibitory learning model of extinction, we are trying to rewire that system through exposure therapy. That was kind of the similarities between the two.
Yeah, exactly. And so we need to create new learning experiences in order to do that, to give the system new information to change how it responds to the same stimulus. And so engaging in escape or avoidance or control kind of behaviors when feelings of anxiety or panic start to show up, that reaffirms sort of the brain's belief, if you like, that these things are dangerous. You're confirming that. You're telling the brain, yes, thanks for the warning. I'm going to do whatever I can to avoid this. You're right. That was dangerous. Whereas what we're doing through a process of exposure is we're telling the brain, no, it's okay. I am actually safe. Look, I'm getting on with things. Look, nothing's happening. And so the same seems to apply to how the pain system works, that we give the brain that feedback that, look, I am safe to move by continuing to move.
And it's the system is, there's not just a switch. I think that's the main thing. It's not just a on off. So I feel like if we were to go through the process of educating at them, just giving them information about pain neuroscience education, they might leave thinking that it's their thoughts that need to be fixed, or it's in their head. So I think the important fact is it's a behavioral exposure therapy. We can't just tell someone about this system, which it's correct information wise, and it is necessary. We need to also back that up with experiential learning so that they don't come away thinking, oh, it's my system's stuffed and I need to just, if only I could turn it off, and then this problem wouldn't be the case.
Yeah, for sure. But having said that though, pain psychoeducation alone, if that's all you give someone, it does have a positive measurable effect on their pain outcomes, 6 months down the track. In the same way, panic psychoeducation as an intervention, if that's all we do for someone with panic disorder, if all we do is give them a 1 hour psychoeducation kind of session on what panic attacks are and how they work, that will also have a measurable positive outcome 6 months down the track. But we can do better than that. You know, that's a starting point. But we can also then be there to kind of assist them through that.
Absolutely. So they still need that information. We can layer that on top with the experiential learning process so that they know what to do with that information.
Yeah. And like everything, you know, there ends up being a lot more, the devil's in the detail, and there's lots of nuance. And so when you actually try to apply this to an individual's like complex life, then you start discovering, okay, well, there's lots of details that we need to tweak, and a lot of it's counterintuitive, and we can easily get lost. And having a coach to kind of take you through that process is obviously going to be a lot better than just doing it on your own.
Absolutely. And there's the common questions that so Pain Revolution was a initiative with trying to get out this information to the public, and there's a few commonalities with the questions that we receive or the presenters receive. So I was going through this with Jason Gardner, so one of the people that were in that educator roles. Some of the questions were along the lines of, I get that, but in my case, So, but in my scenario, it hasn't worked, or so. I think that's a great point. We can give general information, but perhaps information that's specific to the individual in their case, it will stick with them a bit more solidly. Yeah,
for sure.
The value of a coach. Not biased here at all.
Yeah.
The other question I had, and from feedback from our previous podcast, was in relation to patients having a really deep sense of identity with their diagnosis. So they are fused with their scan results or their diagnosis. So using the concepts that we went through about ACT and diffusion, how would you approach that scenario?
Yeah. So in acceptance and commitment therapy, diffusion is one of the 6 core processes of psychological flexibility. And so what diffusion refers to, it's the opposite of fusion. So fusion with thoughts is where if someone is fused with their thoughts, they are kind of acting as if their thoughts are reality. So I guess it would be sort of like the way you feel when you're having a really intense like nightmare. You know, it feels like it's real. There's no space between you and your thoughts. There's no sense of knowing that, oh, I'm having a bad dream and this is just a monster in my mind. You're experiencing those thoughts as if they are reality. So that is fusion. Diffusion is kind of the other extreme of that, where you're able to notice that you are having a thought about a monster chasing you. And you experience that thought as a thought rather than what it is about. So one of the things that, one of the kinds of thoughts that we often get fused with as humans is stories about ourselves. You know, and so you were giving the example of like someone who gets really fused with a particular diagnosis, you know, like I had a car accident, and you know my back is like destroyed, and I've got a herniated disc and a this and a that, and here's the scan, and like this is how my back is. It's completely stuffed and it's very fragile. You know, it's like it's made of glass. And so this sort of this story about the back. And obviously if someone's very fused with a story like that, it's going to have a big impact on their behavior. Right? So you start talking to them about deadlifting or squatting, and they're like, "Whoa, you know, are you crazy? My back's gonna crumble." So I wouldn't, from an ACT perspective, we wouldn't be so interested in, you know, are these thoughts true or not? Although, if you can see like a kind of a, if you can see if you can see like that these thoughts don't seem to match up with reality, and you can see a way into having a useful conversation with the individual that might sort of open their minds up to some other possibilities, then that could be a useful conversation to have. So we're not saying like, oh, don't ever like challenge any incorrect beliefs that people have, especially if you're sitting there as an expert and they view you as an expert on a particular topic. Then if you give them an expert opinion, that probably will change their beliefs. But again, you know, you got to be very careful with that, because they probably, you know, but this is like, oh, but this is what the orthopedic surgeon told me, and you're coming along as, you know, well, you're just a physio. How do you don't know more than this guy? And look, here's a scan, and in our culture, you know, an MRI is kind of like, well, if you've got an MRI, here's a picture. It's almost like it sits at the very top of the sort of the evidence mountain, right? Like, you can't argue with a scan. Here is proof. This is the cause of my pain. So I wouldn't get into any of those kind of arguments. That's not going to work out well for anyone. But what I would invite the client to do is maybe think about when this story shows up, when you notice that, you know, when you are experiencing pain, and this story of like, you know, all the injuries that have happened to your back, and your back as like a, and it would be really useful, obviously, to get the person themselves to describe this story to you, and they might use some metaphors that are, you know, will tell you a lot of information. Like they might use metaphors like my disc has exploded, or my back is very fragile, and, you know, it'll crumble, it's shattered like glass, and these kinds of things. So just drawing their attention to those thoughts, making them aware that, you know, I noticed that when you described your back, you described it like this, and using these words. When those thoughts show up for you, where does that tend to take you? Like, how do you tend to, how does that tend to influence your behavior? And then they might notice that, you know, oh, well, when I think about my back and the scans, and, you know, how fragile it is, then I don't want to do A, B, and C, because I'm really scared that'll put me back in hospital again. Or so as we're kind of working with a client like that, and we notice them sort of being hesitant to engage in a particular activity, or you know, saying that they'll do X, Y, and Z between sessions, and coming back and saying, oh no, I didn't, I had a bit of pain, so I decided not to. We can ask them about, you know, you told me about that story that you've got, or these thoughts that you have about your back. Did that show up for you again? Did that change the way that you were going about your activities? And just inviting them to start noticing where this story tends to show up and how it tends to influence their behavior. That's kind of like the foundations of defusion, is just noticing, being aware, because the strongest sort of fusion happens when we're not even aware that these thoughts are present. That's when they have the most influence over our behavior.
And the thoughts are real as well. So it's that they might, if we, I guess we need to validate that experience first and foremost, because I would feel, especially in perhaps a musculoskeletal clinical setting, where we aren't specialized in dealing with people's thoughts. If we were to say, so you notice that thought or you notice that story, they might feel like, but we just talked about my scan result. So they can't even separate the scan result from the thought. They don't even think of it as just a thought. So I think the important thing is, for like a physio's perspective, to look at how can we bring their attention without invalidating their.
Yeah, for sure. And probably a lot of these, someone's injury story is going to be very important to them, right? Because it's kind of like, it's how they make sense of everything that has happened to them in their life since this life-changing event has taken place. So if you come along and you sort of, if you appear to be, kind of questioning or undermining that sense-making story, that's not going to go well for anyone.
So I guess we need a little bit of time versus, the one session where we've completely invalidated their story, or completely perhaps used so much expectancy violation that they're left with complete, like a black hole, a hole that they need to now the session is about helping them make sense with a new meaning to their story. And that would take a bit of time, I imagine.
Yeah, for sure. Yeah, because it's like, well, what does it mean about the last 5, 10, 20 years of my life if all along my back hasn't been made of glass, and you're telling me, like, I could have been lifting weights, and this whole 20 years of my life that I've missed out on, it didn't have to be like that. So that's going to be a really sort of confronting thing to come to terms with, if that is the case. So obviously that's going to take time, and it's going to have to come from within. It's going to have to come from that person's own discoveries and realizations, not someone sitting there telling them, hey, this is all a lie, because they're going to defend that story very strongly if it's challenged early on.
And they need that sense of curiosity to then explore and figure out things on their own. And then there's probably a sense of loss that they need to deal with after the entire story has been turned upside down.
Yeah, for sure.
So fascinating. So if we were to recap, if this story is now impacting their behavior and getting in the way of them living the life that they want, perhaps we can then use creative hopelessness, or looking at ways to gradually diffuse the situation without taking away everything from them first go, so that they're not ready perhaps for all this sudden worldview change.
Yeah. And that's where defusion is different from challenging thoughts. Because it doesn't matter if these thoughts are true or not, to some extent. A lot of the thoughts that my clients struggle most with, so someone who's depressed might be depressed because they're confronted with their own mortality and the mortality of the people that they love, or they've a relationship has come to an end, and this person doesn't love them anymore, and all the things that are causing them their distress are all true. So if all I've got in my toolbox is like kind of challenging thoughts, then I'm not going to be much service to someone whose thoughts are perfectly correct.
For the case as well where there is a story that someone has that they need to do something, they need to wait for a scan result, they need to wait for the surgeon's opinion first before they start loading, before they start moving, before they start living and going back to the activities. How would you approach that scenario?
Yeah, so this is kind of one of the cool things about ACT is that it's about how you play the cards that you're dealt, not it's not about waiting for the right hand. So okay, maybe you've got some back surgery booked in 6 months from now. What does that mean? Your life is on hold for the next 6 months, or is there something that what would make your life, what would make the next 6 months feel meaningful and worthwhile to you? What would you feel good about in 5 years' time when you look back on these 6 months? What would make you feel proud of how you handled this waiting period? So values are a big part of ACT, and they're about how you live each day, regardless of your circumstances. If everything is taken away from you, if you're a prisoner in solitary confinement, you still get to choose what you stand for in those circumstances, even if all the other choices are taken away from you.
And quickly, Anthony, how would you grab or hold on to or identify someone's values? What's the process that you would generally go through?
I guess I don't really have like a set sort of, there are lots of cool little sort of values discovery exercises that you can do with clients. And I guess I've sort of found over the years that I rely less and less on those sort of, little tools and exercises, and more on just kind of having a very sort of real human to human conversation with the client about what really matters to them, about why they're here, about what they hope to get out of it, what they hope will be different in their life, what they miss in their life that they used to have, that they've lost touch with, and ultimately that's an emotional exercise, not an intellectual one, because what you value is literally what you care about, and caring is an emotional process. And I think the one big tip I would give people if they're thinking about how to kind of help their clients discover their values or figure out what they are is to stay away from sort of intellectual discussions about values. Otherwise, it just kind of ends up turning into almost like a sort of a corporate mission statement type of thing. Oh yes, my values are, compassion and altruism and giving my best and standing up for justice, and those might indeed be someone's values, but if they come from the head, not the heart, then they tend not to really motivate action.
Yeah, and so that's tapping into their whys, their reasons behind their goals, versus giving them like a list of values and trying to kind of tick them off.
Yeah, I mean, and the list of values that you go through and tick off, that's one of those exercises I was talking about, that you can do that with a client, but it still needs to be like a really heartfelt, honest, authentic, vulnerable conversation that you have with them. So it's like you as the clinician, you also have to be willing to be kind of vulnerable and step into that conversation with the client with an open heart and really listen to what matters to them and reflect that back to them as well. And it should be a kind of an emotional conversation.
And then we can use their own words within that emotional exchange to guide them for what is actually meaningful functionally for them. So they might be stuck in, if we go back to stuck in a story that's unhelpful, if we can perhaps work with that story, and then as long as it's aligned to what is meaningful for them, so then we avoid having to go back to the challenging the story narrative.
Yeah, exactly.
Awesome. It's like it's a whole system or something. ACT. I love it. With the other thing we were chatting about earlier was the implications for interventions that are aimed at pain reduction or symptom reduction. So using the context and what the function of the intervention is, there are some interventions that are useful temporarily, though they need to be done carefully to make sure that they are focused on what is meaningful to the client versus just purely symptom reduction or pain reduction. So could you talk a little bit about the nuances with interventions that are aimed at pain reduction and how we can frame them and when can we use them?
Yeah, and I guess this is one of the common misconceptions that people have with acceptance and commitment therapy, that we're sort of like acceptance fascists. Like you just have to accept everything, and if it hurts, too bad. Life is pain, life is suffering. Just kind of suck it up and accept it. And anything that kind of makes life less painful is, that's not ACT. That's kind of ridiculous though. So the key part is that the overriding decision making factor is this taking me towards what I care about? Is this making my life richer and fuller and more meaningful? Is this taking me towards my goals? Rather than, is this going to get rid of my pain? So from that perspective, so if someone is saying like, oh, so, do you think I should continue to take ibuprofen then when I have headaches? That's the question we're asking them. Like, well, if you're having a really bad headache and you take an ibuprofen, do you feel like that would enable you to then participate more fully in this activity, or would you then be willing to go out and do this thing that otherwise you wouldn't do? And it's, oh yeah, definitely. If I can take ibuprofen, then yeah, I can still go and do this and that. Then it's, yeah, fine, take the ibuprofen, of course, why not? But if taking the ibuprofen is part of this kind of control agenda, where the ultimate goal is like, if I take enough ibuprofens every time this pain pops up, I will win this battle against the pain. And then the pain will be gone from my life. And then once the pain is gone from my life, then I can come back to thinking about what kind of life I want to live. that's where we run into problems. But if we're looking at using any kind of intervention that might reduce pain in order to allow someone to have the confidence to engage in more meaningful activity, then we can 100% support that decision, and even encourage it. Because sometimes you'll have the opposite, right? You'll have a client who's like, who's really afraid of using any kind of pain relief. So, oh, I don't want to be dependent on it. And, it's like, it's fine. Don't worry about it. Dependency doesn't come from using pain relief to increase function. Dependency comes from using pain relief to defeat pain.
So with that example, if we have an athlete that uses supplements that are meant for performance enhancement, so looking at sports massage before every game, looking at acupuncture, dry needling every week, looking at, I'm just considering the most dramatic example here, where they're using a lot of the perhaps low value, less evidence-based protocols to get them the performance functional goals that they need. Would that be still a helpful thing for them to be spending their time and money on in the long term?
I mean, I guess, like, if you're Rafael Nadal and you're making millions and, millions of dollars playing tennis, and you really believe that, like cupping before a big match is going to make you win, and, and it costs a couple of $100 or something. Why not? It's probably not doing any harm. But I could see where if people having a sort of a dependency on some kind of intervention might make them less aware of their own sort of self-efficacy, right? That actually you didn't win the game because of the cupping. You won the game because of all the training and hard work you've put in. And so that's what you want to be focusing on, is doing, keeping up all the training rather than getting extra cupping sessions in.
Like the powerlifters that use every single supplement, all the ammonia before every lift, and the pre-lift workouts, and the taping and kinesio tape and all the magic tools. Could they be serving some, like, that can be a way to soothe their performance anxiety, or that could be a way for them to reduce pain, perhaps inadvertently, even though they might be explicitly saying it's for performance gains?
Yeah, it could be. Yeah, I guess, like, as long as the person isn't looking for a specific pain reduction outcome from the intervention before they can compete or perform, then I wouldn't really have a problem with it. But if someone is saying, like, oh, I've got a big match later tonight, and I notice I'm having some back pain. Quick, I need a massage, because I won't be able to perform if this pain is still there. That's where we could start to run into problems.
So they could still perform regardless of having it or not, So they say in an instance, in a context where they don't have their masseuse, they don't have their supplies necessary for them to get that 1%. Suddenly they're thrust into an environment that they don't have it. So is that how there can be some dependency?
Yeah, because if you're looking for a reduction in pain as the outcome, then in the same way that any kind of intervention that you're using to reduce your anxiety, it only works kind of, so far as it works. But as soon as it doesn't work, then it really doesn't work, because now you've got anxiety about the anxiety, and you get sensitized to the pain because you're really fearful of this pain. This pain is going to ruin my performance. It's going to stuff everything up. That anxiety about the pain is going to increase the pain.
It sounds like there's a fine line between how often something can be, or kind of should be used in the long term without robbing them of inability to prepare themselves and be flexible if they can't have that massage or that Theragun or that tool in when it matters.
Exactly. Yeah.
Awesome. So it was a tough question. So it was fascinating to see the whole how the context matters and what are the priorities for this athlete? Is it we want to empower them to know that they can still perform even if they don't have the right socks on?
Exactly.
And what kind of cycles are they perhaps subconsciously creating, like cycles of routines and habits that might not serve them in the long run? And are they willing to change that even?
Yeah.
So I wanted to dive into, before we get to the last question, I wanted to ask if in regards to fusion, if someone is, just as an example, if someone is fused with the belief that they need pain reduction to sleep better, or they need pain reduction first before they get into the next stage of their rehab, in a physio or musculoskeletal perspective, how would you go about with the process of diffusion in that case, where they feel like that pain is fused with their belief that they need to have some kind of symptom reduction first before they can proceed to the next step? So now using ACT, we know that they can work with that pain and still be able to function. So how would you go about that process?
So you're saying that this person tends to get fused with thoughts about not being able to do X, Y, Z in the presence of pain.
That's right. Yes.
Yeah. So, well, I guess I probably wouldn't go straight for X, Y, and Z. I'd maybe go for A, B, and C. And, so something that they have, maybe they notice that they have competing thoughts about, like, so they well, yeah, I'm not sure, actually, no, I think I'll struggle to do that because of the pain, but then again, I'm not sure, maybe I could, so they have some of these thoughts, I can't do it because of the pain, but they also have some thoughts that, yeah, no, actually I probably could do this one because that's kind of like that thing that I did before. And then again, I would just sort of invite them as they did A, B, and C, to notice those thoughts show up. And at different times while they're doing those activities, they might notice, I had that thought then that I wouldn't be able to do this or that because of the pain. But actually, I was able to do it. Or I noticed when I had that thought, that's why I stopped. Actually, it wasn't the pain that made me stop. It was that I pulled back and stopped myself because I had that thought again. Um, and so, so we're kind of helping them to defuse from those thoughts in a context where they might have a little bit more flexibility around how they respond to those thoughts, rather than just going straight for, if they say, "Well, I can't do stairs because of my knees," and you come in with like, "Oh, so like just see if you can notice that thought and just walk up the stairs." So we might invite them to do something else that's sort of a little bit like stepping up a step. So ask them, would there be something that's kind of similar to that you do think you're able to do? And, do you notice, like, if you sometimes have the thought that you aren't able to do it, or, when pain shows up, that your mind might tell you, oh, you better stop because this will cause this or that. So, but you see, even there, like the way I use that phrase, your mind telling you, these are very diffusing ways of talking about thoughts. So we want to do our best as well when we're talking with someone about their thoughts to facilitate that diffusion. And so when I'm talking to someone, I say and say something like, "Oh, sometimes my mind tells me that I won't be able to do something because of this reason." Does your mind ever tell you things like that? That's quite a different way of talking about thoughts from the way we usually do. And so that sort of shift in language will already change the way people are experiencing their thought, because now they're describing their thoughts and they say, "Oh yeah, I notice I do have that thought sometimes, and yeah, when I have that thought, I tend to do this or that. Yeah, my mind tells me that too."
In a way, as opposed to the "I think therefore I am," it's like the mind is now a way for us to separate us from the thought. So that's a really great
Exactly,
way
yeah.
versus just saying, it's just a thought, that, the pain is just a thought, or the idea that you will damage your knee is just a thought. So that's a really great way, and we can use it in our language so they vicariously learn to do the same and separate themselves. That's really great. The mind.
Yeah, exactly. So our language is very important, the way that we talk about thoughts. And yes, you're right. If just kind of saying to someone, "Oh yeah, that's just a thought," I can't see that going down very well with anyone, because that's probably going to create a response where that person sort of holds on even more tightly to that thought. So, whoa, hang on a minute, don't you dare try and take that from me.
Interesting. It's counterintuitive. And the other thing I took from what you're saying in that example is reflecting back to the client in the past when they've had these kind of experiences or thoughts, and they were still able to complete their earlier stage rehab exercises or their other exercises with pain. So that goes back to the importance of, we're not doing rehab pain-free and just aiming to be pain-free the whole way. We're still having a manageable, tolerable level that they're willing to experience from the start. And then we can, when they reach the next level, we can reflect back, "Hey, do you remember that time when you were experiencing pain going up the stairs and it was all good?" "Oh, yes." So now this is going to be the same thing. It's just a little bit more challenging. Are you willing to do that?
Yeah, exactly.
Awesome. There's the final question for you today, Anthony. I know, to kind of encapsulate all of what we've been through, it's really useful to have a real life case scenario. I know you've had your own experience with a persisting pain. So it'd be awesome to hear your insights as well from all you know about ACT as well. So could you tell us your pain story?
Yeah, happy to. Well, it's kind of funny because it's probably only in the last year or so that I've realized that I had a chronic pain story, because until a year or so ago, I thought I had a chronic injury story. So I'll tell you a bit about the history. So in 2008, February 2008, I was injured in a car accident on the way to work. Some guy turned right in front of me at an intersection, head-on collision. Fractured my collarbone, and had quite a lot of bruising on my body and this kind of thing. So interestingly, kind of immediately when it happened, I wasn't in any pain, and I wasn't even sure what had happened, if I'd banged my head on the steering wheel, or this was like I think it was like a 1988 Ford Laser that I was in. So, like no airbags, no crumple zone, none of this kind of stuff that modern cars have, right? It's just like a kind of a metal coffin. So the impact wasn't at very high speed, but a lot of that force was transferred to my body. And so, it's just kind of like initial shock when it happens, big loud noise. But first kind of thing that happened was not any pain. It was me looking around and kind of going, oh, what's going on? What's happening? The first pain that I felt was in my neck. And my instant reaction was, I've done something to my neck. I need to keep my neck still in case, I've injured my neck badly. And so here are all my sort of like, all these narratives I have about neck injuries and being paralyzed and etc. Right. And so I've done something to my neck. I need to keep my neck still. And so I kind of stayed like this in the car, and, people came over, are you okay? And I was like, call an ambulance. My neck hurts. And so then the ambos came, got me out of the car through, and again, their response was, okay, you've got neck pain. We'll like immobilize your neck and and on the stretcher. And the whole way to the hospital in the ambulance, I'm thinking about my neck. Once I get to the hospital and kind of get checked over, and they do all the, can you feel this? Can you feel that? Move this, squeeze my hand, all this kind of thing. And I was starting to get this reassurance that actually my neck's fine. Phew. And so it's like, then the neck pain started to go away. And I started to notice a lot of pain in my torso. So I had quite a bit of bruising from where the seatbelt was, and it was the seatbelt that broke my collarbone. Bruising on the sternum and my lower abdominal area. So just a whole bunch of sort of achiness around the torso. Then they came out and we've looked at the X-rays, and yeah, you've got a fracture on your collarbone. It's a pretty small fracture though. We're just going to put you in a sling, send you home with some painkillers, and come back on Monday to the fracture clinic. Then Monday morning came, and my alarm went off for me to go to the pain clinic. Because I was on a bunch of pain meds, alarm went off and I was kind of out of it. I reached out to turn off the alarm with that arm, and felt a crack and a huge amount of pain. And I could also see where my collarbone had now been sort of like displaced from that movement. And so then I went to the fracture clinic. I had to walk there. in a huge amount of pain, and lots of like fear and worry about like what I'd done to myself. I was like, oh my God, now, now it's going to be a disaster. And, no doubt that was part of what was causing the pain. Anyway, then sort of went through a standard, kind of procedure for a collarbone fracture, just sort of immobilizing and having my arm in a sling for a period of time. The bone healed fine. It was no longer an issue, but once my arm got out of the sling, I needed to build up a little bit of strength again and movement. And that's when I started noticing shoulder pain. So then the next 2 years, for the next 2 years, I was involved in, because I was on the way to work when this happened, it was a workers' compensation claim. It was also a motor vehicle accident, insurance claim. And so for the next 2 years, I was involved in this kind of ongoing legal saga of like making a claim and trying to get compensation and making police statements because the guy was being charged with, reckless driving or something. And throughout this period, still having this ongoing shoulder pain and going to physio and getting injections. And in my mind, I had some kind of shoulder injury that was to do with my collarbone not sort of being set in the right place. And I was going to the physio to kind of like get that fixed through some kind of exercise. I was going to like push it back into where it should be. And because there was this like insurance claim and it wasn't my fault and I deserved to get good treatment. And also there was a kind of like wanting to be believed and taken seriously as well. So I did all the exercises and I went to the physio every week or twice a week, and I demanded like twice a week sessions because I was like, I'm entitled to it. It wasn't my fault. I need it. And so, I mean, at the time I was just like, I was doing what I thought was the right thing to do. And I was like, I've got this injury. It needs to get fixed. I'm going to do this thing. This is all kind of retrospectively. I can look back and I can see what was happening now. Anyway, this 2 years went on and the pain didn't get any better. And, it would hurt to sleep on that side of my arm. I used to just do a bit of sport, sort of social stuff, basketball, tennis, touch footy, throw a ball around, that kind of thing. Whenever I would try and do that, I would instantly get lots of pain in my shoulder. And so I kind of pulled away from doing all those sorts of things. Anyway, at the end of the 2 years, the sort of the legal case was settled. And, my lawyer called me up. He's like, oh, they've made an offer. It's a good offer. If you accept it, come and you can, take a check home today. And I was like, oh, great. It's all over. Brilliant. I've got a file like this thick of all the paperwork that I'd been accumulating over the years. And, it can really turn into like, such a drain, mentally, when this kind of thing happens for a patient. And so I went and picked up the check and I was like, brilliant, it's all over now. And the first thing I did when I got the check was I called up the physio and canceled my appointments, because it was like, well, they haven't been helping. It hasn't made any difference. So what's the point? But really, it's like, well, what was the point before then if it wasn't helping? But I felt like, no, I deserve the physio and, and I need it and I should be going and I want to be a good patient as well. So I'll keep going. As soon as I got the check and it was kind of all over, I was just like, oh, screw it. I can't be bothered anymore. I've had enough. I don't want to even think about it anymore. So then for the next, 5-6 years, I just kind of accepted, I've got this shoulder pain. it's sort of here to stay, but it'll never go away, and I'll never be able to do certain things. So anything that involves, above the shoulder sort of movement, it's out for me. Then about 5 or so years ago, I was trying to make some healthy changes to my lifestyle, and started doing some exercise and lifting some weights and things like that. And I was working with a personal trainer at a gym, and he was just encouraging me, like, look, sort of see what you can do with your shoulder. We'll just start light, and just kind of start low, go slow, kind of thing, and see how you go. And lo and behold, probably after about 6 months or so of lifting weights, I just suddenly one day realized, like, oh, I haven't had any pain in my shoulder for the last 3 months or so. And that was kind of like the beginning of my journey of lifting weights for fun and powerlifting. But yeah, it's funny that in my head, though, I had always thought of it as a really like a structural injury, that there's something wrong with my body that's never going to get better because of this car accident. It's sort of, my body is stuffed, my body's broken. And when, of course, I have pain because there's damage there. But only now, sort of in hindsight, do I realize, yeah, that was chronic pain. The injury had healed, but the pain had not. And I was totally on this, like, pain control mission where I was trying to fight the pain, and the answer was in the physiotherapist's hands, and the massage and steroid injections, and someone needs to fix me because there's something in my body that's broken.
So fascinating, right? Looking back now, and 2 years is a bloody long time as well to go through that entire process. So just to clarify, you didn't really experience too much meaningful functional change from the 1.5 years, 2 years of rehab with the shoulder?
No.
Wow, that's really fascinating.
Yeah. And yeah, I guess when I think about the types of exercises that I was being given as well, it's not surprising because there was no sort of progression that was built into that. We were just coming back each week. Oh, what's your pain like this week? Oh, okay. It's not been that good of a week. Why don't we try these exercises instead then? And look, and this is going back more than 10 years now, and a lot has changed in the pain landscape since then, right? So, no, certainly don't blame the people who are trying their best to help me.
Absolutely. And knowing kind of how the landscape has changed now, if we were, with hindsight bias, looking back, if you had a different approach to your rehab, where the therapist was perhaps less emphasizing your pain levels, and the pain wasn't dictating so much of the progress, what differences do you feel, if any, during this litigation process would you have had?
I guess the first thing would have been to name it as chronic pain rather than an unresolved injury. And for me to understand that my pain wasn't telling me anything useful about the state of my tissues, because I very much believed that it was. And whenever I experienced any pain, I took that to mean that I was doing something that's potentially harmful to my body. So if I had known then what I know now, I think it would have made a huge difference to the way that I approached it. And hopefully I would have started, instead of looking at the exercises as a way to get rid of pain or fix the damage, I would have looked at exercise as a way of building strength and function, which is what I ended up doing, down the track when I started actually lifting for strength. And when I was doing that, that's when I got the pain relief in the end.
After the case was settled, did you experience any changes to your symptoms as well?
Yeah, so a little bit. There was a slight improvement within a few months of kind of quitting physio, and just kind of I just giving up and just going, whatever, I'm just going to have to live with this injury for the rest of my life. There was an improvement over the months afterwards, but then I was left with a kind of a baseline level of pain for however many years after that as well.
There was still that functional capacity gap that you had when you were going back into your sports, you mentioned.
Yeah, so every now and again I'd shoot a few hoops with a friend or something like that, and then suddenly have a acute onset of pain, and then kind of go, okay, look, see this, my shoulder's broken, it's stuffed. I'll never be able to do these activities again.
And it made complete sense if you thought that it was an injury. You were told as well the narrative that it was needed to be fixed. And I'm curious, I wonder how you would approach a similar situation for a client nowadays when they have a condition like this, and they're also dealing with outside litigation, outside work compensation factors. There might be some anger issues. There might be some perceived injustices. How would you deal with all that?
In a single sentence?
as basically as we can. We can expand on this perhaps.
Yeah. So in its simplest terms, I guess just by validating that whole experience, and acknowledging how difficult that is, and all these factors, all these things that are going on for them, and the loss that they've experienced, and the anger that they feel, and all of that stuff is totally understandable.
I think that's a perfect way to succinctly manage 2 years of a litigation process. So just getting through the validating their experience versus just solely perhaps treating the pain. So using the validation in the process of treatment.
Yeah, because remember, as soon as you appear on the scene, you become part of that person's context. And so, we know that that pain takes context into account. So you're having an influence on their pain one way or another, whether you intend to or not. So if you actually think about what are the kinds of positive influences that I can have, if you create a context of social and emotional support and trust and understanding and warmth and encouragement and compassion all these kind of things. Well, we know those are the kind of things that are going to have a very positive influence on the person's experience of pain and their willingness to then engage in the types of things that are going to help them in the long run.
The
So yeah,
benefits of
like
empathy.
don't underestimate how much power you have as a clinician in someone's life who is coming to you with a problem like this. And that influence isn't necessarily explicit either. It's not necessarily in the exercises that you prescribe them or the intervention that you perform, but in these other sort of contextual influences, the environment that you create for the person to engage in a process that will be healing.
The non-specific effects and the power of empathy. And quickly, what do you bench and overhead press now?
So 135 kilos is my best bench press. The overhead press was definitely the one that I could never have seen myself. I mean, even just an empty 20 kilo bar 5 years ago, or maybe a bit more, would have seemed completely out of the question for me. My maximum overhead press that I've done was like a 91.6 or 90.6, whatever 200 pounds is. I worked it out to the in kilos. You got to pick an arbitrary milestone, right? So that's what I picked. So yeah, 200 pounds.
Fantastic. Awesome. It's always about the rounded numbers in the end.
Exactly. Yeah.
The powerlifter's ego. Mate, it's been an absolute pleasure. We went through a lot of valuable takeaways, I'm sure, and we'll get some great feedback, and we might even have you for part 3 if you're keen, and if Dora behind you is okay with that. The pet
I'd love
snake.
to. Yeah.
Awesome, mate.
Sounds good.
If people didn't hear the first podcast, they should definitely listen to it right now. But if they haven't and they're keen to reach out to you, where can they find you?
So just my website, anthonyberrick.com.au, or find me on Facebook. That's about the only social media that I'm active on.
Awesome. So thank you, Anthony, and enjoy the rest of the weekend, and until next time.
Cool. Take care.